this is a case of a white cataract, and obviously it's not the hyper mature, but it's a very mature white cataract. And I was just going to go through the surgical procedure mostly. Like, did you want to say something about the preoperative assessment?
Not the basic stuff like B-scan, ultrasound, and all that. But I was going to say, yeah, but three kind of more specific pearls that I always use is, one is the rate of visual loss, because some of these mature cataracts, the visual loss is very rapid, and those are the ones where there's often a big osmotic effect, and you've got a very high anterior lens curvature, and the relevance of that is those are the ones that tear out, you know. And similarly on A-scan biometry, I always look very closely at the lens thickness, because again, you know, the greater the lens thickness, particularly once you go past 5.0, 5.2 millimeters, you've got higher anterior lens curvature, greater risk of problems with the rhexis. And finally, I always say to patients that not only may it take 2 operations, you know, if there are zonular problems and maybe subluxation or dislocation of the lens, but the one thing you can't predict is posterior capsular plaque. And some of these plaques, no matter how hard you try, you can't get them off at the time of the operation. And so you're committing the patient to a secondary YAG laser capsulotomy. So I warn them that sometimes, you know, it's going to be necessary to do 2 procedures, either 2 operations or an operation and a laser before they get their optimum visual rehabilitation. So those are just the kind of, you know, higher end pre-op pearls, I would say.
Yeah, I think these sort of cases are very complex, and you do need to spend more time with the patient preoperatively, because the visual outcome isn't as certain as, say, with your routine type of cataract, and it's usually a case that takes a bit longer. You may well get, you know, more corneal edema. There's a risk of that lens posterior dislocation, and may require secondary procedures like vitrectomy. So it's very important to prime your patient for the potential for more complications than, say, the more straightforward type of cataract. And you made a point with the A scan too. I think that's very important to anticipate potential problems. And if you have got that very high dome anterior capsule, you know you're going to be in for a very difficult rhexis. Also with the A scan, you can't do IOL master. The IOL master, even the IOL master 2, just won't get through these white cataracts. So you'll need to do a manual A scan and base your IOL measurements on that manual A scan. If you enjoyed this lecture so far, please subscribe to http://iop.vision. I hope you enjoyed this series as much as we have putting it together. Thank you.